Today, we're sharpening the bedside skills that truly impact cardiac patients' outcomes. From rapid perfusion assessment to hemodynamic targets, we'll cover it all. No fluff, just evidence. First, assess mental status, skin temperature, capillary refill, pulse quality, respiratory effort, urine output, and lactate trends. Remember, lactate reflects tissue perfusion, but must be interpreted in full clinical context. Calculate the mean arterial pressure, or MAPE, using this formula. Systolic plus 2 times diastolic, divided by 3. Aim for at least 65 millimeters of mercury in shock, unless a specific target applies. Scenario: a 68-year-old post-operative patient becomes pale and restless. Blood pressure is 85/50, pulse 120, respirations 28, and urine output has dropped below 20 milliliters per hour. You calculate MAP, 62. This confirms inadequate perfusion. Immediate action: fluid bolus, oxygen titration, and prepare norepinephrine if hypotension persists. Oxygen strategy matters. Give supplemental oxygen if hypoxemic, but avoid routine use in normoxic cardiac patients. Maintain normal saturations during resuscitation to prevent the harm of hyperoxia. Fluids come first, but use them wisely. Start with balanced crystalloids for septic shock. Reassess often using exam findings, vitals, lactate, or bedside ultrasound. Consider albumin only after large crystalloid volumes, following SCCM guidance. If hypotension persists after fluids, initiate norepinephrine as the first-line vasopressor to reach a MAP of 65 or greater. Add vasopressin if escalating doses are required, and consider inodulators like dobutamine for cardiac support. Reassess every 5 to 15 minutes. Monitor mentation, MAP, urine output, skin perfusion, and lactate trends. Timely reassessment and early antimicrobials are key in septic shock bundles for improved survival. In chest pain and acute coronary syndromes, ECG and troponin are your compass. Obtain a 12-lead ECG within 10 minutes and repeat if symptoms continue. Use high-sensitivity troponin with serial algorithms for faster and more accurate diagnosis. Avoid the old MONA autopilot. Routine opioids and oxygen in normoxia are not first line. Follow guideline-driven antiplatelet and antithrombotic protocols based on STEMI or NSTEMI risk. Recognize STEMI early. Look for 1 millimeter or more of ST elevation in contiguous leads. Trigger immediate cath lab activation or transfer if PCI isn't available. Every minute counts. In heart failure decompensation, identify quickly whether the patient is wet or dry, warm or cold. Wet and warm needs diuresis and afterload reduction. Wet and cold needs cautious vasodilators or inotropes if hypotensive. For chronic heart failure, ensure evidence-based quadruple therapy once stable. Watch renal function and potassium when escalating diuretics or MRAs. Reassess congestion by exam, weights, intake, and output, and use ultrasound if available. For peripheral artery disease, screen patients with exertional leg pain, non-healing wounds, diabetes, CKD, smoking history, or age over 65. Manage PADI comprehensively. Control blood pressure. Use ACE inhibitors or ARBs, and ensure antiplatelet and statin therapy. Recognize acute limb ischemia fast. Pain out of proportion, pallor, pulselessness, paresthesia, paralysis, and poikilothermia. This is a vascular emergency. Initiate heparin and escalate to vascular surgery without delay. ECG accuracy saves time and lives. Confirm lead placement before interpreting. Address rhythm threats immediately. Follow ACLS algorithms for unstable tachycardia or bradycardia. In the first hour of septic shock, recognize hypotension or elevated lactate. Draw cultures and start antibiotics promptly. For cardiogenic shock, identify hypotension with signs of hypoperfusion and pulmonary congestion. Secure oxygenation. Start norepinephrine and add dobutamine if cardiac output is low. In acute chest pain, repeat ECG and high-sensitivity troponin testing. Risk stratify and activate pathways. For acute decompensated heart failure, position the patient upright and provide oxygen if hypoxemic. Document timelines precisely. Onset of symptoms, ECG times, troponin results, fluids, and vasopressor starts. Rapid-fire pearls. MAP of 65 is a starting point. Individualize for chronic hypertension. Troponin trends outperform single values. Treat both the limb and overall cardiovascular risk aggressively. Master these assessments, hit the hemodynamic targets, and chart in real time. That's how recognition becomes recovery. Every time, with precision, safety, and excellence.